Hello, friends. I'll be talking on this briefly on role of hyperbaric oxygen in wound healing, with a emphasis on whether this can prevent amputation. I'm sure many of my intensive care friends must be wondering as to why I'm talking on this. So tomorrow, or 14th November, is the World Diabetes Day, and as you see, this is the hyperbaric machine that we run as a unit in a Smart Revive Center. So the reason I'm talking is I'm a HBOT qualified, and so this the hyperbaric oxygen certification was done way back in 2007, and we run this hyperbaric chamber. And World Diabetes Day, which is happening on 14th November, the theme for that is access to diabetes care, and the focus is to prevent diabetes-related complications. That is the theme for 2023 World Diabetes. So I believe it's imperative that I need to talk on how we prevent the complications, which is focus mainly on preventing the amputation following diabetic food. So that is the reason. And this is how the HBOT chambers look. Even for children, one can offer HBOT. So as I said, the reason I'm doing this, I'm a HBOT qualified. So way back in 2007, I have done a certification course. And all the HBOT chambers in Australia came under the Department of Anesthesia and Critical Care. So every state had a multi-place export chamber. So for all my intensive care friends, this is a dimension where intensivist has a big role to play and possibly should edify themselves on the nuances of hyperbaric if they're interested in this science. So that is the backdrop. And even I've had a publication, so I wrote a review article on hyperbaric oxygen during COVID. So that's about the background as to why I'm talking on HBOT. So we look into the background. So the data I'm showing is a 2014 data in India. So globally, so every 30 seconds, one lower limb is being amputated. So that is the magnitude of the problem with regards to diabetic foot, leading to ischemic legs and leading to limb amputation. So this is a quite staggering sort of a data from the world. Every 30 seconds, a limb is being amputated, one lower limb. So we need to look what is our Indian data. So obviously our Indian data is a little sketchy. So the data that we have from 2014 sort of a reference is in India, there are 1 lakh leg amputations every year happening. And this has been reported from Vascular Society of India data. And that is also quite a staggering number. And in India, as per 2014, there are around 62 million diabetics. And 25% of diabetics in India develop some sort of diabetic ulcer or foot, some sort of ulceration which needs care, and some sort of a diabetic foot, and eventually some of them leading on to more morbidity and amputations and so on and so forth. And if you look at this burden, so most of my listeners would know that when we talk about diabetes, we in ICU we pay attention to more of kidney problem, heart problem, stroke. But this problem of having diabetic foot, which accounts to 25% of the diabetic population, is greater than the kidney disease, greater than the diabetes related cardiac disease, diabetes related stroke, diabetes related eye disease, and neuropathy. So, which means the burden, which seldom we speak about and talk about and campaign for, is much greater than some of these diseases which we commonly see in ICU. We see diabetes with CKD, we see diabetes with ischemic heart disease and coronary artery disease. We see diabetes related stroke. But diabetic related foot ulcers and ischemic legs, diabetic foots are much more common and they're more burdening. So 84% of the diabetic ulcers or foot that develops is related predominantly to people who walk barefoot. And more often, when people are walking barefoot, on a hard surface or on a surface which has sharp objects like stones or gravel. So that becomes the nidus or inciting or a trigger for developing diabetic ulcer. And most of the listeners can sort of reconcile that in India, there are many reasons why people walk barefoot. So especially the elderly population visit a lot of temples and such places, religious places where barefoot walking is considered norms. All these add on to the risk of diabetic foot in more so in our population. It could be religious places or it could be rural places. Walking on barefoot is an important sort of a trigger in diabetic, and 84% of them do develop when some sort of an injury happens walking in a barefoot. And it is said that approximately an individual walks 150,000 kilometers in a lifetime. So that is the sort of the utility of the legs. So that is the importance of a leg, that so much it is used and there is a lot of wear and tear in one's lifetime. And what is the cost burden of an amputation? So it is shown that for a 50-year-old male who gets amputated, and someone who is off the work for about 6 months secondary to amputation, the cost burden for an Indian on an average comes to around 10 lakhs rupees per for around 6 months. So that is the sort of cost burden for an amputation, for an amputee or amputation. And this is much higher than the kidney disease and the heart disease. So this is the backdrop, and World Health Organization has put an enormous emphasis, especially in India, in countries like India, which are emerging as diabetes capital of the world, to put emphasis on preventive foot care. So there's a lot of emphasis now being put on preventative care for the foot and taking care of the foot to prevent these complications, morbidity, and and limiting their lifestyle. So this is the backdrop about the burden of diabetes, foot, and ulcers in India. So now let's jump into hyperbaric. So so this was a publication that came in US in 2009, where they showed that even in a country like US, outpatient wound centers over 15 years has significantly increased in lieu of foot ulcers and diabetes complications from 100 to 1000 wound centers specified. I'm sure this is the data from 2009. So now this you can possibly multiply by 10x. So that would have been the increase with OP wound center. And when you look at the evolution of hyperbaric, it started off in 19th century. The whole concept of hyperbaric oxygen was mainly given for decompressive sickness. So in especially deep divers, so this was the science. Basically, it is giving oxygen under pressure to achieve supranormal oxygenation in the body. Later on, the indication for hyperbaric extended in 1961 to 62, extended to carbon monoxide poisoning and gas gangling. So as a life-saving procedure. So this is how the hyperbaric usage evolved. Then in 1977, there was a whole textbook that came on hyperbaric condition, which means you can see it is as old as 19th century. And by 1977, there was a textbook on hyperbaric elucidating its role in various conditions. So today here we are only focusing on the diabetic foot and vascular wounds. So this is the progress it has made. And if you're wondering, hyperbaric may not still have a role in the modern science. And if you look into the literature, sir, this is the number of publications that that are currently existent in for the role of diabetes. And if you look, there are more than so many thousands of publications. Sorry. So it's around close to 8,794 publications. And if you look at only for wound healing, there are around 440 publications and 59 publications for post-surgical flaps and grafts optics. So once they do a skin graft for any malignancy cancer, so the role of HBOT is very much established there. And 121 publications in osteomyelitis, and these are all the review articles, 26, and so on and so forth. So basically, close to around 10,000 publications are there in this science of HBOT as of now. So now we'll jump into what is its role in wound healing. And as you see, the maximum publications are in wound healing. So, and there is level 1 evidence for lot of these skin conditions, especially the non-healing ulcers, osteomyelitis, compartment syndrome, and crush injuries. So there is level 1 indications for HBOT. So what happens in wound healing? So there are different phases for the wound to heal. Initially, they need to have a bleeding, then there is an inflammation, then there is proliferation, and then there's remodeling and the healing of the wound happens. So why non-healing happens is that when the wound is stuck in this inflammatory place, where there is perpetuation of ongoing inflammation, and it does not transit to proliferative phase because of wound hypoxemia. That is when the wound becomes chronic. So where there is inflammation which is getting perpetuated in the setting of hypoxia at the wound level. We are talking about tissue hypoxia, not systemic hypoxia, and that's when it goes into chronicity. So HPOT has a role in mainly transiting the wound from inflammatory phase or the hypoxemic phase to the proliferative phase and helps in formation of collagen. So why it is important? Because hyperbaric oxygen significantly reduces because it creates enriched enrichment of oxygen at the tissue level. And we know, all the listeners would know that the organisms grow in anaerobic conditions or where there is hypoxemia. So because you're enriching, you are superoxygenating the tissue. So infection is mitigated and there is reduction of inflammation. Most importantly, because there is enrichment of oxygen at the tissue level, capillary reperfusion happens much more effectively. There is improvement in the phagocytosis at the tissue level, and there is neoangiogenesis because there is enrichment of oxygen at the tissue level. New vessel formation happens, which is terribly important for good wound healing. I'm sure most of you who do the wound dressings, you know, when there is a granulation tissue, we are very happy. When the wound is bleeding, we are very happy because there is new vessel formation. And diabetes, that is the problem because of the hypoxemia, there is no new vessel formation at the wound, and that's when it goes into the chronicity. And HBOT helps in reducing a lot of inflammatory markers like intracellular adhesion molecule. And most importantly, it increases because it improves the enrichments, it enriches the tissue oxygenation, it improves the local nitric oxide production, which leads to vasodilation. So that is also important for effective wound healing. So HBOT increases the local nitric oxide level at the tissue level. So this is some of the molecular mechanisms in which HBOT or hyperbaric oxygen is found to be helpful. And it also mitigates the reperfusion injury because it increases nitric oxide, which causes vasodilation, and that helps in reduction of reperfusion injury also, which is also a problem in diabetic foot. So this is just summarily the mechanisms at the tissue level in which HPOT acts. And hyperbaric oxygen, as I said, it helps in transition of the wound from the inflammatory to proliferation phase, and it causes activation of this proline hydroxylase, which is needed for synthesis of collagen, which is needed for tissue healing. So these are some of the mechanisms how hyperbaric oxygen helps in wound healing. So now I'll straight away jump into now we know the hypothetical sort of an understanding how HBOT helps at the wound healing. But what we are interested as clinicians is whether there is robust evidence to say that HBOT helps in wound healing. So there are a good number of articles, and I showed you there are around 400 odd articles in diabetic foods. I'll pick up only the salient key articles. So if you look at this, this came from Germany in 2005, systematic review of hyperbaric oxygen in the management of chronic wounds. So this was a systematic review where they took 5 trials on diabetic ulcers, 118 patients. And here specifically they looked at whether HBOT was successful in reducing the risk of major amputation. So as you see, in 118 patients, it did reduce the risk of major amputation with a relative risk of 0.31, and this was statistically significant. For minor amputation, there was no influence. Venous ulcers, HBOT was effective in significantly reducing the wound size. So this was an article that came in 2005. Then when you look at randomized controlled trials, there are 3 high-quality randomized controlled trials in diabetic foot ulcers. So 3 high-quality. So I've taken 6 good quality randomized controlled trials. So this is, as this is an old study, Faglio et al. From Italian group, 1996, 68 patients. The age group of patients was 63 plus or minus 9. So they had the grading of the wounds for a severe grade, Wegener 2 to 4 grading, 68 patients. And even here, if you see 38 randomized to HBOT, 33 in the control. And amputation, they looked at amputation rate significantly less in the group which got HBOT as compared to control. So in HBOT studies, what one needs to look at scientifically is TCOM, which is tissue concentration of oxygen monitoring, was found to be high. All the studies you will see, they would have done tissue concentration of oxygen to see whether there is a enrichment of oxygen at the tissue level. And it was very good in this at 21 to 23 millimeter mercury. And you'll see subsequently how this tends to increase with HBOT. And the type of HBOT that is given is therapeutic HBOT is what one needs to consider for wound healing, where we give at 2.2 to 2.4 atmospheric pressure absolute. So this is at the 2.2 to 2.4 pressure we give for 90 minutes. And the number of sessions that was given in this study was 38 plus or minus 8 sessions were given. Okay. So this is the second study which came from UK, Abidio et al. 2003. Small study, 18 patients, and here the age group was much higher, 71 plus or minus. So again, the wound severity was Wagner 1, 2, and they looked at healing. So healing at 6 weeks, as you see, HBOT was 100% as compared to 54% in control. And complete healing at one year happened in 5 out of 8 patients. In control, it was 0 out of 5. And for all the listeners, the HBOT we give therapeutic HBOT when we say it has to be around 2 to 2.4 atmospheric absolute. So that is the pressure at which we give. So we give at that high pressure so that the super enrichment of oxygen happens at the tissue level. And for all the listeners, the HPOT is always the sessions are for 90 minutes, 1.5 hours. It's easy to remember. And the sessions that are recommended for any medical conditions is around 30 to 40 sessions. So just keep that in mind. The 2 to 2.4 for wellness. You would have heard of a lot of wellness clinics offering HBOT. So these HBOTs are not the ones which can be used for the medical grade because they give atmospheric absolute at around 1.2 to 1.4. That is not enough for medical. For medical grade HBOT, and in fact, we have a pride in saying in Bangalore, we were the first ones to have got the HBOT, therapeutic HBOT after the command hospital. So we were the second ones who got the HBOT machine to Bangalore after the command hospital. So we have the first one to get the medical grade. Before that, there were a lot of non-medical grade. So now HBOTs are present in at least 6 to 7 hospitals. So this is the evidence from good study and adverse events were nil. And if you see again, focus on this tissue concentration of oxygen monitoring was more than 40 millimeters mercury at the tissue level. That is a very good oxygenation. So this was again a French trial. So which came in 2003, 27 patients. The mean age was 64 plus or minus time. Small, all HBOT studies, as you say, are smaller studies because it's not easy to get big numbers in this. So here the wound grading was Wegener 1 to 3, 14 in HBOT, 13 in control. So this is during HBOT, tissue concentration of oxygen, you can see it's at a very high level during the therapy. And the control, as you see, it is low. So that is the difference between the tissue concentrations of oxygen that you attain when HBOT is being given. And day 15 healing also happened in 41% as compared to 27%, which was significant. So these are three good studies, high quality RCTs, which show very good benefit with regards to enhancing the wound healing and most importantly, in its ability to reduce the risk of amputation. You saw a German meta-analysis, Italian study, both showing a good sort of a effect in mitigating the amputations. So I'll talk about other three medium quality studies in diabetic foot ulcers, but again by Faglio et al. So this was a much larger study, 115 patients where very bad wounds were taken with Wegener's grade 2 to 4. Even here, if you see, they looked at amputation rates for 14% in HBOT as compared to 31% in control, statistically significant. Adverse events were nil. And tissue concentration of oxygen was 28 plus or minus 13 millimeters. So this was a US study, Zamboni et al. It was a prospective cohort study, age group 60 plus or minus 10 patients. And during HBOT, you could see tissue concentration while HBOT is being given reaches at a very, very high level, supranormal levels, 563 as compared to 80, and 7 week healing was significant. So this was a good study from Sweden, Palani et al. Prospective cohort study. So here 38 patients, and as you see, tissue concentration of oxygen reaches at a very supranormal levels. And even here, if you see, the risk of amputation was significantly less in HBOT as compared to control. And healing happened in 76 as opposed to 48. Adverse events was found only in one patient. And if you see all these studies, the atmospheric absolute, the pressures at which HBOT was given was all more than 2, Most of it range from 2.2 to 2.5. So if you see all the studies. So these are all the 6 studies that have shown good quality studies in wound healing in hyperbaric oxygen, use of hyperbaric in wound healing. So these were few other studies. Baroni et al., again, Italian study, showed amputation was 11% as compared to 40%. And there's another study which showed amputation 5% versus. So you have enough and more studies to indicate, send a strong signal that HBOT was effective in reducing the risk of amputations in these patients. I'm sure all listeners have seen the burden of amputations in India despite whatever advances has happened. So I'm only proposing that HBOT can be a good adjunct to all the good surgical procedures, all the other medical therapies that one adopted. This could be considered as an adjunct. So I'm not here to say this will replace the good surgical procedures or angioplasties that happen, but it can be used as a good adjunct to prevent amputations is my only submission. So now we'll look into whether HBOT has a role in non-diabetic foot ulcers. So this is a study, Krollman et al., where they have looked only at non-diabetic foot ulcers. The retrospective cohort study, age is 69. They looked at arterial ulcers. And as you see, healing with HBOT was 70%. In controls, it was 11%. And the change in tissue concentration of oxygen was more than 10 millimeter mercury. And all this, if you see, they have used 2.2 to 2.5 atmospheric absolute for 90 minutes and 29 sessions. So just to keep in mind, the 30 sessions is what is 30 is the bare minimum, 30 to 40. But in India, seldom people will go on to 30 because by 20 sessions, I'll show you some of the case studies. By 20 sessions, they very well improve and they stop the sessions most of the time. So this is again a Swedish trial in non-diabetic foot ulcers. So they looked at stasis ulcers. They looked at 4 weeks area, and as you see, the area of healing had significantly improved in the sense the area of ulceration had reduced in 78%, and 6 weeks area had reduced to 64% as compared to 97% in control. So the healing was much better in these stasis ulcers. This was an Israeli study case series. The mean age was 53 plus or minus 18. 35, they looked at 35 patients with vasculitis ulcers. As you see with HBOT, complete healing happened in 80%, partial healing in 11.4, and no healing in 8.6. So this is in non-diabetic foot. Mainly they have looked at arterial ulcers, stasis ulcers, or vasculitis ulcers. HBOT had a good impact in enhancing the healing process. And most importantly, HBOT has purported to be useful in graft and flap uptake, especially complex onco surgeries where they have undergone radiation. The only way you can get the flap to be successful and not undergo rejection is use HBOT, and there are good number of studies. I'm not going through that. There is a separate video where I've gone through even the studies looking at the graft and flap uptake. And always tissue concentration of oxygen more than 50 millimeter mercury if it is achieved. It was shown that 100% successful flap uptake happened. So these are the references for these studies. So now we'll move into, so we spoke about diabetic foot ulcers, non-diabetic foot, and osteomyelitis. And I'm sure every listener know how troubling can it be to treat osteomyelitis. And in refractory osteomyelitis, obviously you will give antibiotics for very long time, even up to 6 months or 1 year. Along with this, one should consider HBOT as an adjunct to enhance the healing of osteomyelitis. So this was a study, case series, 40 years, where they had osteomyelitis of tibia and fibula, and the cure was attained with 2.4 ATA in 89% of the patients with osteomyelitis. So this was again a case series, 40 patients with femur osteomyelitis, and cure was attained in 85%, and recurrence happened in around 15%. So this is again a study from Taiwan. So case series 13 patients with osteomyelitis. So cure happened in 92%. So all in all, you'll see that even in osteomyelitis, although these are all old studies, because the newer studies, this is well established indications now that osteomyelitis in many of the Western countries, HBOT has become a norm. There are a lot of HBOT clinics that are mushroomed in US. So it's almost become a norm that osteomyelitis are put into HBOT as an adjunctive therapy because of all the signs that have shown improved healing in these patients. Because otherwise, each one of us know how difficult it is to attain good healing in osteomyelitis. So then talking about radiation, the HBOT in radiation oncology, some of the indications are radiation necrosis. So in radiation injuries, there's no other alternative treatment except enriching the oxygen at the local site. So radiation necrosis, osteoradionecrosis, because these wounds just don't heal, and HBOT remains the only sort of a treatment modality. And it's also important even pre-radiotherapy. Therapy with HBOT enhances the effectiveness of radiotherapy is what has been shown in studies. And as I said, enhancement of radiotherapy for with the pre-radiation HBOT is found to be more effective. And even the post-radiation side effects like cerebritis or inflammatory changes in the tissues, all that can be mitigated because HBOT has a significant anti-inflammatory role. So radiation cystitis is another complication that we treat, and it is refractory to most treatment modalities, and HBOT remains the only sort of a treatment modality. And even radiation myelitis, pneumonitis, HBOT has a role to play. So the take-home message is there is good evidence for HBOT, definitely with all the studies that we have reviewed in reducing the risk of amputations, mainly diabetic foot ulcer, crush injuries, and skeletal muscle compartment syndrome. And here, this is where the level of evidence is very robust. And even in crush injuries, the recommendation is grade 1A in crush injuries and compartment syndromes. In diabetic foot also, there is a good level of evidence. And as we have seen, HPOT promotes partial and complete healing of wound problems. Most importantly, in the flap surgeries, especially in onco sector, HBOT has a important role to play, and even in radiation injuries, it remains a mainstay of modality. Radiation necrosis, osteoradionecrosis, and pre-radiotherapy treatment to enhance the effectiveness of radiotherapy. And there is moderate evidence of HBOT promoting healing of arterial ulcers and vasculitis and calcifitic. So we saw how HBOT is useful in diabetic foot wounds, even in non-diabetic foot ulcers like arterial ulcers or venous stasis. HBOT has a role to play. And we said promote salvage of compromised flaps and grafts, especially in a complex flap surgeries. And we've seen the evidence for HPOT promoting remission of refractory osteomyelitis. So overall, the treatment cost, the benefits outweigh the risk because there's hardly any risk. It's a non-invasive sort of a modality, and it is safe, effective, and it is cost effective as well without posing any risk to the patient, and it is absolutely safe. So I'll just take you through some of the cases that we have done at our center, and how we have seen the results, even with regards to saving the foot from amputations. So this was a 87-year-old female who had a left lower limb ischemia, category 2B femoral and popliteal. So surgery was done for this patient. So there was a left common femoral artery endarterectomy with distal thrombectomy with anterior tibial artery angioplasty. All these procedures was done for this lady, and this lady was scheduled for a limb amputation as a salvage measure. So there was pain and discoloration of left lower limb. As you see in the plantar aspect, you could see that there is discoloration, and this was meant for lower limb amputation. And she had a non-healing wound, and she could not walk, and there was a risk for amputation. So HBOT was initiated at our center. After 6 to 7 sessions, she had on a very intolerable pain, and she got a good relief from the pain. After 10 sessions, as you see, if you see this lower diagram, so the discoloration has started reducing. And further 10 sessions, there was sloughing off of the infected skin. As you see here, there was a lot of infected skin and discoloration. So there is sloughing of it. And with 20 sessions, as you see, there was a complete healing of the wound, and this patient did not have to undergo limb amputation. So this is a case in example in our own center where a lady who had undergone complex sort of a vascular surgery, endarterectomy with angioplasty and scheduled for limb amputation as a salvage measure came to HBOT and the limb was saved. And this was another patient, 58-year-old male, no comorbids, and as you see, he has a buccal mucosa cancer. and there was a surgical resection done, following which there was chemotherapy and radiotherapy. So obviously this patient had a lot of pain and swelling, and you can see in the figure there is a lot of discharge of pus because of the radiotherapy. So there was the radiotherapy induced sort of a injury happening there, and there was a pus discharge from the operated side. There was a flap put in, and there was a infected sort of a flap, and he had difficulty in speaking and eating as well. So post HBOT after 10 sessions, it, see the key thing about HBOT is the pain immediately comes down. The pain comes down, swelling comes down, inflammation comes down, and the infection is controlled because there is super enrichment of the tissue, and where the bacterial infection automatically gets mitigated. And further 10 to 20 sessions, first discharge stopped, and as you see, the discharge is already come down here. And after that, flap was fully healed. So that was about this cancer patient where HPOT was helpful. And this was a 37-year-old female with no comorbids with a cancer of the salivary gland. She had a cancer of the left salivary gland. And post radiotherapy, there was a non-healing ulcer. So hyperbaric oxygen was given at 2.5. As I said, all medical HPOT should be given more than 2.2 to 2.5 HTA for 90 minutes for 20 sessions. And obviously, this patient had difficulty in speaking and chewing food. After 10 to 12 sessions, as I said, any HBOT, the pain and swelling immediately comes down. After 20 sessions, there was a complete ulcer healing with good proliferation and maturation phase. And this is in one of the patient who had arteriovenous malformations, 58-year-old male, no comorbids with AV malformations, where patient underwent surgery with a groin flap repair. And obviously, there was a non-healing ulcer, and there was difficulty in doing activities of daily living, as AV malformation was in the hand, as you see. So HBOT was given for 2.5 ATF for 15 sessions, and after 5 sessions, the swelling came down. 10 sessions, there was an enhanced healing. So this was our experience with some of the very gruesome sort of injuries. As you saw, one patient had a good limb saving. We could save the limb from amputation. The second patient had a lot of discharge, and the flap uptake was compromised, which was mitigated. And the third patient, you saw there was a salivary gland tumor, obviously that got good healing, and AV malformation. So this has been our journey, and we have treated close to around more than 150 patients with HBOT with various sort of vascular injuries with great outcomes. So on this World Diabetes Day, so it is good to ponder about these adjunctive therapies and try to enhance our skills in these new modalities of therapy. So thank you one and all. You can visit my website www.drpradeepnagapa.com to rehear to this lecture. So thank you one and all.